This recording will go over allergies and allergic reactions. Concepts that we'll explore include immunity and inflammation. Inflammation is normal for a patient if they get injured or if they're ill, right? Inflammation is part of the immune response, and that's considered normal and helpful. The problem is if that inflammation and immunity response is excessive, it can cause harm and damage to the patient. Allergies are also known as hypersensitivities, and they occur in the presence of an allergen to which the patient usually has been previously exposed. It's characterized by an overactive immunity with excessive inflammation. And just a little A&P review, an allergen is an antigen that triggers excessive inflammation and immunity overreactions only in susceptible individuals. And those allergies or hypersensitivities could be very minor, like watery eyes, sneezing, runny nose, also known as rhinorrhea, or they could be life-threatening with allergic asthma, angioedema, which we're going to discuss, or anaphylaxis. There are 4 types of hypersensitivity reactions you need to be familiar with. Type 1 hypersensitivity is also known as anaphylactic response. And type 1 hypersensitivity is the most common type, and it's caused by excessive inflammation caused by overactive immunity. Type 1 reactions result from the increased production of immunoglobulin E and causes acute inflammation when immunoglobulin E responds to an antigen such as pollen and causes the release of histamine and other agents like histamine. And that histamine and agents that are like it, similar to it, is what causes the runny nose, itchy eyes, angioedema, and anaphylaxis. Let's see. So it could be mild runny nose. It could be life-threatening with anaphylaxis. With anaphylaxis, and we'll talk specifically about it in a little bit, it affects the blood vessels and actually causes blood vessel dilation. So what would occur with your patient's blood pressure if their blood vessels dilated? Hopefully you're thinking there would be a decrease in blood pressure. And how would that affect the patient's cardiac output? Just the same, right? If we have a decrease in blood pressure, we'd have a decrease in cardiac output with anaphylaxis. Some common agents that cause type 1 hypersensitivity reactions or an anaphylactic reaction could include bee stings, medications, iodine, latex, peanuts, pollen, shellfish, allergic rhinitis, also known as hay fever. So type 1 is the most common type of hypersensitivity reaction, and it's probably the one you're most familiar with. Type 2 is also known as cytotoxic mediated responses, and they occur when the body makes autoantibodies directed against self cells that have some form of a foreign protein attached to it. Some examples of a type 2 reaction include drug-induced hemolytic anemia, hemolytic transfusion reactions when a patient's receiving the wrong type of blood or blood product during a transfusion, and hyperacute graft rejection of organ transplant. So when a patient rejects a transplanted organ. Type 3 is also known as immune complex reactions, and they result from excess antigens causing immune complexes, so things that build up, complexes are formed in the blood, and those complexes shouldn't be there, right? And they can end up plugging up small blood vessels of the kidney, skins, and joints and causing issues. You learned about a type 3 immune complex last semester when you learned about rheumatoid arthritis. This semester we'll talk about lupus, which is a type of type 3 immunocomplex hypersensitivity reaction. The 4th type of hypersensitivity reaction is also called delayed type hypersensitivity reaction. And the reason is because it occurs 12 to 72 hours following exposure. Now, you don't have to memorize the number of hours, but you need to understand, like it says in its name, that it's a delayed hypersensitivity. So the type of reaction can cause edema, induration, which would be like a hardened area of the skin, ischemia, tissue damage. A thing to know about type 4 hypersensitivity is that it isn't caused by histamine like the others. So I wouldn't take an antihistamine like Benadryl for a type 4. Type 4 would usually be treated with a corticosteroid to try and treat the symptoms, but an antihistamine wouldn't help because histamine doesn't play a role in the problem for type 4s. Common examples of a type 4 reaction include contact dermatitis, so when the skin gets irritated with clothing, detergent, jewelry, as well as insect stings. Angioedema might be a new term for you. It's a severe type 1 hypersensitivity reaction that involves the blood vessels and all layers of the skin, mucous membranes, and subcutaneous tissues in the affected area. Angioedema response is a deep tissue problem of immunoglobulin E mediated release of inflammatory proteins, especially bradykinin. Although angioedema can occur in any part of the body, it's most often seen in the lips, face, tongue, the throat, the larynx, or the neck. Intestinal angioedema, so if it's not in the head and neck area, can cause abdominal pain, cramping, nausea, and vomiting. But of the two types, so if you have one patient and the angioedemas in their lips, their larynx, their tongue, and you have another patient, the angioedema, we're just sort of splitting them apart and we're saying they're experiencing it in the intestinal area, they have abdominal cramping, nausea, they're vomiting. Which patient would be your priority patient? Hopefully you're identifying the patient who has swelling of the tongue, the throat, facial swelling, because you're worried about our priority concern, which is airway, right? So we're going to focus on angioedema of the head and neck, mouth, tongue, because that's the one, that's going to be what kills the patient, right? If we have swelling of our tongue and our throat, that puts the patient at risk for airway occlusion, right? Upper airway occlusion. So if that swells shut, there would be no movement of air. So that's considered a medical emergency. When you have a patient come in with angioedema, maybe they got swollen lips, their tongue feels a little swollen, feels a little weird in the back of their throat, we want to get a history, if time allows, because there's certain medications that are prone to causing angioedema in patients. One big one is ACE inhibitors. So, what does your ACE inhibitor end with? Do you remember the suffix, the common suffix for ACE inhibitors? Hopefully you're thinking pril, lisinopril, right? So your ACE inhibitors, why is your patient normally taking that? Blood pressure. So a good question would be, are you taking any medications for blood pressure? And we're listening to hear if they're going to say, I'm on an ACE inhibitor, something that ends with pril in its generic name. We can also ask about NSAIDs, including aspirin, which are associated with causing angioedema. We're going to do a physical assessment of the patient. Can we see that their lips are swollen? Are they complaining about it itching or tickling in the back of the throat? Do we have swelling of the face, lips, tongue, or neck? Difficulty speaking or drinking, or any nasal swelling? Severe angioedema of the face or mouth is considered an acute medical emergency because we need to maintain their airway. In addition to watching for difficulty swallowing, we want to listen for any stridor. So stridor is an adventitious lung sound, and it results from occlusion of the upper airway. So while wheezing with asthma is the lower airway, tinier bronchioles of the lungs, stridor would tell us that our airway is closing. So the big tube where air is moving in and out, if that closes, there's no air movement. It's considered a medical emergency. So you want to recognize stridor on NCLEX style questions as a medical emergency where you're going to need to have backup. This is an emergency. We're worried about the patient losing their airway. They may need to be intubated. They're in trouble. So I was working once in the emergency department, and a guy came in with some facial lip swelling. He said, it's happened before, but it seems worse. I just started at the store, I went home, took a nap, and I woke up and it's getting worse. And so we got an IV in him and got some medications going. But what question did we ask him? Are you on anything for blood pressure? What was he taking? A medication that ended with pril, an ACE inhibitor. that gentleman, he got the round of medications that we'll talk about here shortly for allergic reactions, and they weren't very effective for him. He was not improving and progressing slowly, but still getting worse. His jowls started getting bigger, a little bit more edema, and I worked at a community hospital emergency room at this time, so the doctor decided to intubate him, even though there was no stridor at this point, but in order to intubate him while he was able to, right? And then he got shipped out to a different hospital. So it is a very important thing that you recognize angioedema as life-threatening because we're worried about that airway closing off. So interventions for angioedema include ensuring the adequate airway, stopping the reaction. Let's say the patient's having a medication infused and they start having this allergic reaction. We'd stop infusing medication if we're worried that's causing it. Oxygen if needed. They might need intubation or a tracheostomy if we can't intubate. And then medications. And we'll talk about medications for allergic reactions while we're talking about anaphylaxis. So our next topic is anaphylaxis. So what's the difference between anaphylaxis and an allergic reaction? Anaphylaxis is like the allergic reaction that's out of control and is going to kill you. Okay? It's a life-threatening type 1 hypersensitivity reaction. It can be very rapid. Systemic, what does that mean? Systemic means it's affecting my whole body. Even though a bee stung me in my right hand, my blood pressure's dropping from my fingertips to my toes, right? So it's affecting my whole body, and it can be fatal. There's a picture here of some angioedema with that facial swelling, which can sometimes accompany anaphylaxis. So for health promotion for anaphylaxis and allergies, we want to try and avoid allergens if they're known, wear a medical alert bracelet, make sure healthcare providers know about any specific allergies. That's why we ask patients every time they come in what sort of allergies they have. That's why we check against the MAR, the listed allergies, before providing medications to our patients. And they need to have their EpiPen and know how to use it properly. I'm going to let you look in your textbook about the information for EpiPens that are listed in some boxes in the textbook, but I'll point out some things that sometimes students aren't as familiar with. So they understand Epi. We're going to go into it a little bit more in depth next class, but the patient should always have 2 EpiPens on them. So not left in the car. It gets below freezing in the winter and is baking in the summer, right? It's on them so that those temperature variations don't affect the medication, as well as to make sure they have it if they need it. So 2 pens on the patient. Why 2? Because we worry if you give yourself, you get a bee sting or whatever your allergen is, and you have an allergic reaction, and you give your EpiPen. That Epi, the mechanism of it might wear out before the allergen goes away. Sort of simplifying that. But what I'm saying is the allergen, the problem, could last longer than the medication. So you give your EpiPen, you call 911, you're waiting for the squad, you're out in the country, whatever. It's taking long. If the Epi starts to be not effective, you have a second pen that you can treat yourself with. Another one, so we need to call 911 after using it once, even if we're feeling good after using it. Still have to be evaluated by the physician. And a patient can give Epi through their clothing. They want to avoid seams or thick areas of clothing. So not what we learned in lab for best practice on how to administer something, but in an emergency situation, we want the patient to give it. They can give it through their clothing. All right, what are we going to assess our patient for? Initial symptoms can be kind of vague. The patient may have a feeling of apprehension or impending doom, that feeling like I feel like something bad's going to happen. Generalized itching or urticaria, which is those hives with subsequent angioedema, redness. The histamine and other mediators can cause inflammation, bronchoconstriction. So those are the airways in the lung. If I have bronchoconstriction, that means the airways are getting smaller, right? So harder for air to move. Mucosal edema, excessive mucus production, all making it hard for air to move in the lungs. Worried about congestion, rhinorrhea, which is runny nose. Dyspnea, difficulty breathing. Adventitious lung sounds such as wheezing, crackles, reduced breath sounds. A big emergency one, remember, is stridor. That's telling us our airway's about to close off. In NCLEX world, stridor as well as drooling are cues that you need to recognize as indicating your patient is losing their airway. Other things, the patient often has, this is a big thing we're worried about with anaphylaxis, specifically anaphylactic shock, hypotension. So those blood vessels dilate and the blood pressure goes down, and it goes down so low that the body can't perfuse its vital organs. So what happens to a patient who has anaphylaxis? Their blood vessels dilate and their blood pressure goes down. What happens to their pulse? Does it go up or go down? Initially it goes up because the body's trying to compensate. So they'll have a rapid, weak, possibly irregular pulse. Okay, so then let's look at what are we going to do for the patient. Priorities would be establishing, maintaining, stabilizing the airway. So intubating them if they need, tracheostomy if it's necessary. Also, even we want to consider removing the source of the allergy if that is still something the patient's being exposed to. Medication-wise, epinephrine, antihistamines, corticosteroids. And we're going to talk about those in class together. But at this point, you'd want to recognize those three as three medications that could possibly be used. It talks about recumbent positions with legs or feet elevated. This is interesting. So up until this point, the majority of the time we're talking about patient position, we have said, let's elevate the head of the bed because it improves oxygenation. This one's a little different. We're saying lay them down and let's elevate the legs and their feet. Why would the patient with anaphylactic shock, at this point, when you hear shock, think very low BP, can't perfuse my vital organs? Why is that patient having their laying down with their legs and feet elevated? So that the blood can get back to vital organs, right? Because the blood pressure is the problem with that patient. Maintaining O2 saturation and monitoring pulse oximetry for the patient is a priority. Within your textbook, you have a box about emergency care of the patient with anaphylaxis. It lists some other medication, antihistamines, which makes sense, right? Like diphenhydramine, which is Benadryl. Also some other histamine 2 blockers, like famotidine. Let's see here. We talked about steroids already. Vasopressors in addition to epinephrine, possibly glucagon, albuterol. It also talks about infusing normal saline because if the problem with anaphylaxis is my blood pressure is dropping, then one of the ways we can treat it is by increasing fluids to drive up that BP. So the treatments we'll get into a little bit more in depth when we're together next week, but that should get you started with allergies, angioedema, and anaphylaxis. Bring any questions you may have to class next week.